Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to a new session from a film reading sessions. And as usual, we start with a neuro cases. This is a 32 years old patient who came for an MRI brain. This is the axial flare and axial T2 weighted images. We can clearly see there is a rather fairly defined space occupying lesion, intraventricular space occupying lesion, with epicenter of the lesion is seen at the body of both lateral ventricle. This lesion in T2 is showing a high T2 cystic areas within. These or private T2 cystic areas within, multiple cystic areas within the lesions. This lesion is seen extending inferiorly to obliterating most of the third ventricle, and further downward it is seen extend along the aqueduct of Sylvius and reaching the region of the fourth ventricle here. So it seems that the lesions is an intraventricular showing or extending along the ventricular system. Main bulk of the lesion is seen at the body of the lateral ventricle and is seen extending inferiorly till the fourth ventricle. The lesion, as we see here, it show a multiple cystic lesions, as it's seen here in the post-contrast images. These cystic lesions is in a post-contrast image does not take contrast enhancement, but the solid component of the lesions show enhancement here. So it is partially solid, partially cystic lesions in intraventricular in a young adult male. So we put the differential diagnosis in such lesions. There is two main possibilities in an intraventricular mass lesion in an adult, either subependymoma or central neurocytoma. This is apparently not subependymoma, as subependymoma usually non-enhancing and usually smaller in size, and it can occur in the lateral ventricle but typically occur at the inferior aspect of the fourth ventricle. So it is clearly not subependymoma, and this leave the possibility of central neurocytoma on the top of the differential diagnosis. And if we see here that the lesion here is to some extent attached to the septum pelosum, and this is one of the characteristic feature of the central neurocytoma. If you see an intraventricular mass lesion in an adult showing some attachment or relation to the septum pelosum, you should think about central neurocytoma. So this is likely to be central neurocytoma, as it is attached to the septum pelosum, and as we described the lesion before, it show areas of cystic areas of degeneration, and this also one of the characteristic feature of the central neurocytoma. It can be entirely cystic lesions, giving the characteristic polycystic appearance, and as we say, this is one of the characteristic features of the central neurocytoma. In this case, it is seen extending inferiorly to the third ventricle and to the fourth ventricle. This is some to less extent or to some extent it is an rare presentation or rare appearance to extend to the inferior ventricle, but it is mentioned in some textbooks that these lesions can extend to the third and even to the fourth ventricle. The lesion is seen inseparable from the surrounding and displacing the surrounding structure, the thalami and basal ganglia, and even the brainstem that exhibit a high T2 and flare signal. It could be a compressive edema or possible infiltration from the mass lesion. We can see here also there is an supratentorial hydrocephalic changes evident as dilatation of the left lateral ventricle. The right lateral ventricle here is seen collapsed due to the applied shunt tube here, and while the left lateral ventricle is seen dilated due to obstruction of its foramen of Monro outlet foramina. And this again usually occur in central neurocytoma, as the central neurocytoma origin usually arise near to the foramen of Monro and usually obstruct the foramen of Monro and associated with hydrocephalic changes. The third ventricle is not appreciated as it is nearly obliterated by the mass lesion, and the only evidence of the hydrocephalic changes is seen at the left lateral ventricle that is being trapped by the mass lesion. So in summary, this is a typical case for a central neurocytoma occurring in a young adult, and as we said before, the central neurocytoma usually occur at a young adult from 20 to 40 years old. This is a 32 years old patient, so this is a typical age presentation. It shows an attachment to the septum pellucidum, and this is one of the characteristic features for central neurocytoma, cystic area of degeneration, and this is one of the characteristic features of central neurocytoma and associated hydrocephalic changes. This is again one of the complications occur in central neurocytoma, but here the slight atypical presentation is the inferior extension involving the third ventricle and the fourth ventricular extensions, and this is one of the rare presentation in central neurocytoma. Okay, this is a young male patient who came for MRI brain, and this is the MRI T2 axial images and the MRI flare. Here we can see here that there is multiple lesions seen at the both frontal lobe. The larger lesion here is seen at the left frontal, anterior frontal, high frontal regions. It's seen exhibiting a bright T2 signal and high flare, and in T1 weighted images we can see that the lesion is here. This is the T1 weighted images is low in T1 weighted images. This is a fairly defined lesions, low in T1, bright in T2, and high in signal in flare images. It's apparently that these lesions are not surrounded by significant mass edema, mass effect, or significant vasogenic or perifocal edema, and this is an important in description of the space occupying lesion in the brain if it is associated or not associated with a significant edema. We can see that there is a similar to other smaller lesions, one in the right frontal region and the other in the body of the corpus callosum, crossing the body of the corpus callosum. It can be seen in the sagittal image here. This is the lesion that is occupying and crossing the body of the corpus callosum. So we can summarize the differential diagnosis of such lesions by the affection of the corpus callosum. To narrow the differential diagnosis, we can summarize the lesion that cross the corpus callosum, as we know that the differential diagnosis is a little bit small. It could be either glioblastoma multiforme and the lymphoma and the demyelinating process on top, tumefactive MS on top of the demyelinating process that cross the corpus callosum. So here we have three diagnostic possibilities: either glioblastoma multiforme, that lesion that cross the corpus callosum, glioblastoma multiforme, lymphoma, and tumefactive MS. we can exclude glioblastoma multiforme, as the glioblastoma multiforme usually associated with significant mass effect and significant vasogenic edema. There is no significant mass effect or vasogenic edema in such lesions, and also the multiplicity is also decrease the possibility of glioblastoma multiforme. The second two possibilities are either lymphoma or tumefactive MS. Lymphoma and tumefactive MS can occur in a multiple lesion like this. So to differentiate, and both are conditions can be usually not associated with a significant mass effect or significant vasogenic edema. Either lymphoma or tumefactive MS can't be usually not associated with a significant mass edema and mass effect. So to differentiate between lymphoma and tumefactive MS in such lesion, we should look for the post-contrast images. This is the post-contrast images here. We can see that the lesions, most of the lesion does not take enhancement, and this is against the lymphoma. Usually lymphoma take some uniform enhancement in the post-contrast images. So this is makes the possibility of lymphoma is less likely. And in these post-contrast images, we can also see that there is an incomplete ring enhancement. The enhancement is peripheral or marginal and incomplete. This is the characteristic incomplete ring enhancement that is characteristic for the tumefactive MS or demyelinating process. So in the post-contrast images, this make the possibility of demyelinating process or tumefactive MS is the most likely diagnosis here in these cases. And if we revise the T2 pattern of such lesion, the bright T2 signal here of the center of the lesion is usually occur in tumefactive MS. And if we noticed also, there is some sort of linear traversing structure here. This is linear traversing structure is usually representing venule structures or cerebral venules that the demyelinating lesions are usually centered upon. And again, this is one of the characteristic features of the demyelinating process and tumefactive MS. So this is multiple or three lesions here likely representing tumefactive MS or tumefactive multiple sclerosis. Again, we can also, a point of differentiation between tumefactive MS and lymphoma is the diffusion, but here the diffusion is corrupted and missing. So we can depend upon the only here the post-contrast enhancement. In lymphoma, the diffusion show diffusion restriction, while in tumefactive MS it is usually free diffusion. Okay, this is a 45 years old patient who came for the CT pulmonary angio, as he did or an X-ray chest was done for this patient and revealed a pulmonary nodule. So he requested for CT chest or CT pulmonary angio. This is the pulmonary nodule seen at the most inferior basal segment of the right pulmonary nodule. This the right lower lobe, the inferior basal segment of the right lower lobe. This is well-defined pulmonary nodule. We can see here a characteristic features that there is two vascular structures are seen supplying this pulmonary nodule. We can see here, this is the two vascular structures are seen supplying the pulmonary nodule. So such a pattern is usually representing a pulmonary EVM, arteriovenous malformation. Once you see a pulmonary nodule with a vascular structure supply, hypertrophied vascular structure supplied such pulmonary nodule, you should suspect this is a pulmonary EVM. And in the pulmonary EVM, it is usually a fistula it is not a true EVM. It is usually a fistulous communication between the pulmonary artery and pulmonary vein, inducing the pulmonary nodule. In the pulmonary angio post contrast, we can see the intense enhancement of the pulmonary nodule, which representing the site of the fistulous communication between the pulmonary artery and pulmonary vein. And we can see here the draining vessels or supplying vessels. We can see here one of these vascular supply is arising from the pulmonary artery, the right pulmonary artery here. This is the arterial supply, and this is the venous drainage that is draining from via the inferior pulmonary vein. Is arising from the inferior pulmonary vein. So this is the vein and this is the artery, and both are enhancing and hypertrophied in the same phase, indicating that there is an arteriovenous shunting. So this is characteristic for high flow vascular malformations. Here this is called pulmonary EVM, but it is in textbook it is called EVM, and this is the famous name, but it is an AV fistula. It is a fistulous communication between the arterial pulmonary artery and pulmonary vein, and this is the fistulous communication between the artery and the vein. The artery is hypertrophied and the vein is hypertrophied due to arteriovenous shunting, and the vein is opacified at the same phase of the arterial phase due to also arteriovenous shunting. The pulmonary EVM or pulmonary AV fistula can be supplied by one artery or multiple arteries, drained by one vein or multiple veins. In this case, it is supplied by one artery and drained by one vein. In these reconstructed images, it is better appreciated in these reconstructed images. We can see here this is the pulmonary nodule or site of the arteriovenous communication, and this is the hypertrophied arterial feeder and hypertrophied draining venous drainage. So this is a typical example for pulmonary AVM or AV fistula. Okay, this is an 18 years old patient who came with accidentally discovered hepatic focal lesions by ultrasound, multiple hepatic focal lesions, and ascites, abdominal distension and ascites by ultrasound. So he came for a triphasic study of the liver. This is the arterial phase, this is the portal, and this is the delayed phases of the liver. We can see here there is a multiple variable sized, well-defined lesions. These lesions are seen taking an intense, rather uniform intense enhancement in the arterial phase. Here, this is the intense enhancement seen in the arterial phase, except that central areas here usually representing central breaking down within the lesions, but most of the lesions are taking enhancement at the arterial phase, and this is an indicate that the hypervascular nature of such lesions. Okay, if as we described in the scheme of the hepatic focal lesions, if the lesions take enhancement in the arterial phase, it usually one of the three possibilities, either HCC or hepatic adenoma or focal nodular hyperplasia. So we look for the delayed or subsequent phases to see if there is a washout or not. If there is a washout, it looks like it likely to be HCC. If there is no washout, this is could be a hepatic adenoma or focal nodular hyperplasia. In the portal and the delayed images here, we can see that the lesions become hypo-intense to the liver parenchyma in the portal phase, and in the delayed phase it is hypo-intense to the liver parenchyma. So this is lesions show washout. So these lesions can't be adenoma or FNH, as this lesion does not exhibit washout in portal or delayed phases. So this puts the possibility of HCC in the top of diagnostic possibilities. However, we can see here that the liver is not cirrhotic. The liver here is not cirrhotic. The margin is smooth. There is no enlargement of the caudate loop. So we can in this case we usually slightly can't be confident to say that these lesions are HCC, multiple HCC. Also, the other reasons that can make us not so confident for describing this lesion as an HCC is the multiplicity of such lesions. The multiplicity of such lesions in a non-cirrhotic liver may raise the possibility of the metastatic nature of such lesion. So there is two reasons for making the possibility of HCC is less likely, the non-cirrhotic condition of the liver and the multiplicity of the lesions. So if we considered a metastatic process in such a lesion, we should consider something important, that the lesions here is a hypervascular. So this is if we consider a metastatic process, this is a hypervascular metastasis. And as we know that the hypervascular metastases have a limited primary, as most of the hepatic deposits are usually hypovascular, but a small number of metastatic process to the liver is hypervascular. The limited primary origin for such hypervascular lesions are either from the renal cell carcinoma, pancreatic neuroendocrine tumor, the carcinoid from the bowel, and from the uterus we can say that uterine choriocarcinoma, and from the thyroid we can say thyroid carcinoma. Some types of thyroid carcinoma can send hypervascular metastasis. So in such lesions, hypervascular, and if we suspect that these hypervascular metastases, you should look carefully for the pancreas, for the renals, for the bowel, and for the uterus to exclude primary lesions. If we see here, if we go downward in the images here, we can see there is a large mass lesion here involving the pancreatic body and tail. These mass lesions is hypervascular, as it is intensely enhancement at the arterial phase. The lesion is taking intense enhancement at the arterial phase. So this is a hypervascular lesion seen at the pancreatic body and tail. This hypervascular lesion, the hypervascular or intense enhancement of such lesion in the pancreas, make the possibility of pancreatic neuroendocrine tumor on the top of diagnostic possibility, as we know that the pancreatic adenocarcinoma, which is by far the most common tumor occur in the pancreas, is a hypovascular in nature. So this is not a pancreatic adenocarcinoma, and if we see a hypervascular lesion in the pancreas, we should put the pancreatic neuroendocrine tumor in our differential diagnosis. So this is likely to be a pancreatic neuroendocrine tumor, and as we know that there is the pancreatic neuroendocrine tumor, there is either non-functioning or functioning tumor. The lesions that reach a large size like this is usually non-functioning, and as we know also that these lesions usually have a cystic area of degeneration like this, and may show areas of foci of calcification like this. So these lesions show the typical presentation or typical signs of pancreatic non-functioning neuroendocrine tumor, large enhancing or hypervascular lesion showing large areas of cystic areas of degeneration and foci of calcification. Also, we can see here that there is a extension of the lesion posteriorly infiltrating this structure, which is the splenic vein. We can see here, this is the splenic vein. This is the splenic vein here that come to the portal confluence to make the portal vein. This splenic vein is seen infiltrating by the mass lesion, and again this is one of the characteristic feature for the pancreatic neuroendocrine tumor, that is infiltrate the surrounding vascular structure with intraluminal thrombosis. The thrombus is similar, showing the same pattern and same enhancement of the lesions. So all these features are typical for pancreatic neuroendocrine tumor, and the lesions in the liver is usually hypervascular metastasis. So these lesions are not multicentric HCC, they are metastatic deposits, hypervascular metastatic deposits from large pancreatic neuroendocrine tumors. Okay, this is a 50 years old patient who came for ER with a severe abdominal pain. He did an X-ray. We can reveal that there is air under the diaphragm with an air fluid level seen at the right diaphragmatic, inferior to the right diaphragmatic copula. He did an CT after that, and we can see that there is the air here. This is a pneumoperitoneum seen in the X-ray, plain X-ray, and this is the fluid collections, and this is the air fluid level. So this is clearly a case of pneumoperitoneum. If we see a pneumoperitoneum, you should look for two things. The source of the air loculi, or the air in the peritoneum, usually come from perforated viscous, or from less likely from air forming organisms. So the most common cause for pneumoperitoneum is ruptured viscous or perforating viscous, and the most common site of perforating viscous is the stomach and the duodenum, due to penetrating or perforating a peptic or duodenal ulcer. And if we see here, this is the stomach, and this is the antrum, and this is the first part of the duodenum. We can see here there is a focal defect at the anterior wall of the duodenum. This defect here with an air loculi is seen extending outside the lumen to the peritoneal cavity. So this is a focal defect here, clearly focal defect here, and this is one of the typical sites for duodenal ulcer, and this is a case of duodenal ulcer perforation with a moderate pneumoperitoneum and free fluid collection. So if you see a pneumoperitoneum, the stomach and the duodenum is usually one of the characteristic sites, or one of an important site you look for any defect for such source of the pneumoperitoneum. And you also if they are looks normal, you can search for another perforating viscous, another viscous, or another bowel perforating, but most likely the source will be the stomach or the duodenum. There is an important sign that can indicate the site of perforation. Usually the perforation not clear like this case. It can be very small and can't be appreciated. Usually search for the site of perforation adjacent the maximum amount of pneumoperitoneum. It usually present nearby the maximum amount of the pneumoperitoneum, and this could be a good clue for the site of perforation. We can also make the patient take oral contrast to see the site of the leakage, as in this case. We can see here, this is the site of leakage from the site of the focal defect in the duodenum. This is the site of leakage, and this is again one of the methods that can help us to identify the site of perforation. Okay, this is an MRI shoulder for the 44 years old patient who came with limited range of motion. We can see here that clearly seen in this coronal stair images that there is a diffuse marked thickening of the inferior glenohumeral ligament. See, this is the inferior glenohumeral ligament is marked thickened and high signal with near obliteration of the axillary pouch. This is the inferior glenohumeral ligament. See here is markedly thickened and obliterating the axillary recess or axillary pouch. This usually indicate the signs of adhesive capsulitis or frozen shoulder. In the sagittal image here, we can see another site, important site for adhesive capsulitis is the rotator interval. This is the space between the subscapularis and the supraspinatus muscle. This is the rotator interval that show the intra-articular long head of biceps tendon. We can see here that there is dark T2 signal here obliterating the rotator interval, and this is again one of the signs of adhesive capsulitis. And this is the coracoid, and this is the subcoracoid fat planes that is also obliterated by the thickened capsule. And if we see here, this is an advanced actually an advanced case of adhesive capsulitis, that most of the capsule here is thickened and the most evident at the inferior glenohumeral ligament or inferior aspect of the joint capsule. So this is an adhesive capsulitis or frozen shoulder. Last case here is also an MRI shoulder for a 39 years old patient who came with a presentation with an pain and loss of motion for or range of motion for the shoulder joint. We can see here there is an diffuse edema pattern involving the supraspinatus muscle here and the infraspinatus muscle here. So this diffuse edema pattern respecting the muscle fibers, this is the teres minor, this is the infraspinatus. So this diffuse edema pattern involving the whole length of the muscle and respecting the muscle boundaries with no evidence of fiber disruption. So we should think about denervation injury. In such a pattern involvement of the supraspinatus and infraspinatus, we should look for the suprascapular nerve. And as we know that the suprascapular nerve is passed along the suprascapular notch and then the spinal glenoid notch. The spinal glenoid notch can be appreciated at the axial images. This is the glenoid, this is the spine of the scapula. So this is the space is the spinal glenoid notch. So in the coronal images, this is the glenoid, and this notch is the spinal glenoid notch, and this is the nerve is the suprascapular nerve. There is no mass lesion occupying here the spinal glenoid notch. And if we go upward, follow the course of the nerve, we can see this is the suprascapular nerve here. We can go upward, this is the suprascapular nerve. Okay, this is the suprascapular nerve, and this is the base of the coracoid process. The notch that is medial to the coracoid process is the suprascapular notch. So this is the other important site for compression of the suprascapular nerve. You should look for this is the suprascapular notch, and this is the spinal glenoid notch. These two sites are important for compression for the suprascapular nerve. Here we can see there is no mass lesions occupying the both sides of the suprascapular nerve. So in this examination, we can say that these lesions are denervation injury with no possible mass lesion compressing the course of the source of the course of the suprascapular nerve. In this case, it could be the denervation injury could be related to an injury of one of the roots of the brachial plexus. So we can do an MRI brachial plexus, or can due to an viral infection affecting the suprascapular nerve, which is called personage Turner syndrome, and this is usually clinical diagnosis, and there is affection, viral affection of the suprascapular nerve with no evidence of mass lesions. But in our examination or in our study here, we can say that there is a denervation injury, pattern of denervation injury of the suprascapular nerve and and the infraspinatus, supraspinatus and infraspinatus muscles, with no evidence of mass effect along the course of the suprascapular nerve for further clinical and further workup assessment to exclude the other possibilities for such denervation injury, either idiopathic or viral infection, or some affection to the brachial plexus nerve roots. Thank you. I hope these were interesting cases, and hope to meet you soon again, inshallah.